So I am Dr. Anshul Shah from Jaipur. We are having a anorectal surgery setup in Jaipur. So this is the Vaaft material which you have. Like this is, I think this is the laser pointer. So this is the table which you are using. You are using a similar table for the laparoscopy also. And this is the scope inside. This is the miniaroscope, and near about 4 mm is the diameter of it. And this is the this fistula, this forcep is there, and then we have the brush and all, so that you can debride the tract. And this is how you have to do it. The procedure comprises of two phases. One is a diagnostic phase, in which you have to localize where the internal opening is, and second is the operative phase, where you have to distract the granulation in the tract. So first of all, its role in the supralevator fistula. So what is the supralevator fistula? Basically, sometimes the intersphincteric fistula goes up. So this is the supralevator portion which it has formed. This is the supralevator fistula. And also at times supralevator fistula may have this external opening. You leave down this opening, we have to just focus on this tract, that how we have to deal with this tract. This is where the scope can go inside and can let you know what you are not able to see. And at times also, high transsphincteric fistula has a branch in the supralevator portion. This is a blind ending tract where you can't see it. So at that time, the Vaaft can help you. So this is a small case which I will be showing you. This is the tract. You can see this is the high transsphincteric tract. We have removed the tract, and now we are going inside. I'm more of a radical surgeon. I prefer removing all the tract. So this is the tract we have removed. Now I am curating this portion of the supralevator extension. This is the high transsphincteric fistula with the supralevator extension. So after curettage, the thing is we can't see inside. We can only curate it. So at this time, we can just see, introduce the Vaaft scope inside, and the thing is, we can just see what is going inside. So after cleaning, what we do is, we take a roller gauze, we take the gauze inside, and what we do is we thoroughly rotate the gauze so that the tract is cleaned up. And after proper cleaning, after proper curettage, you can just see this is the gauze which comes out. So after cleaning, what we can do is we can just put a scope inside. Now we have put our scope inside just to check what is going on inside. Is it everything is cleaned up or not? Is there any granulation left? Is there any debris left inside? So we can just remove all of it. So after just checking it, we can, even this scope helps you to wash, because it has a good pressure inside. So the pressure goes inside, and also we wash it. And definitely we can also do it by the help of a syringe also. That is not much deal. So this is how the image appears to be inside. And you can see this is the granulation. We can, if we see some granulation is there, we can remove it either by using this brush, either by using the forceps, or even by a simple curettage. So this is again how the laser ablation is being done, as you saw in Dr. Kalyankar sir's lecture, that we can ablate everything under vision. So this, whenever you are doing this fistula, this scope has an advantage that you can just see what is inside. So after doing this, what we do is we repair this sphincter. So this is how we are repairing the sphincters. They are simple sutures we are taking PDS 20 sutures to repair it. In case if the muscle bulk is more, we can use PDS 10 number also. So these are simple sutures we are taking up. So after taking these simple sutures, what we'll do is the sutures should never be under tension first of all, because in case if they are under tension, they will break apart. So there should be very less tension in them, and the thing is this space will be leaving, this space, this open, this the hole which is going inside, we'll be leaving this open. We can put a drain tube inside so that it helps to the proper drainage of the collection. Also we can wash by this tube. We can just put saline washes from this. So this is how the repair is done, and this is how after what we put the tube inside. So we are putting the tube inside, the patient will go with the tube inside. You can see these are the sutures which are being taken, so the sphincter is approximated fully. So this is this space which is going into the ischiorectal fossa, and this is the dressing which is being taught to the patient. So we can remove these drains near about after 7 to 8 days when this granulation of the tract takes place, so that patient can wash it up, and we can give him this syringes are coming in the market by which we can wash inside. So this is how it comes out to be, and this is the final image of the patient with this drain inside. So as you also heard by Dr. Kalyankar sir, that we can also use Filac with this Vaaft. So the basically we have all a principle for any fistula surgery that we have to excise the offending gland and then you have to ablate the fistula tract. So the role of this laser and this Vaaft lies only in the interior transsphincteric fistulas. They are the direct low transsphincteric fistulas or interior fistulas are there. So this is the left procedure in which you disconnect both these glands. You just remove the intersphincteric portion and then you laser ablate it. So in this case, you can do a laser ablation. You can just remove this gland from here, then you can laser ablate it, and you can also do it under vision of a scope. But there are some problems, like this is a similar case, and this is having a collection, as you can see it over here. There is a 12 to 2 o'clock, there is a collection inside. So if any collection is there inside, and also at times we are having a supra, this you can just see this is the supralevator portion which is going inside. So if you do a laser of this tract and you do this excision of this tract, but the supralevator portion is left inside, then the thing is it will lead to again recurrences. So at times you have to judge between whether you have to use Vaaft or you have to do with a regular fistulectomy and sphincter repairs. So the conclusion is it has a good role in supralevator fistula and also in interior low transsphincteric fistulas. The videoscope makes it under vision and it is not a blind procedure, and each fistula is unique and its management is based upon multiple factors: type of fistula, associated abscesses, recurrent fistula, associated incontinence, and experience of the treating surgeon, and no single technique is perfect, so you have to choose accordingly. Thank you. I have one more talk. I think if you allow me, I can continue it again. Yes. So this was the role of Vaaft. Now my next talk is complex fistula in N1 PSR. So you all heard about all the minimal invasive things now. So I am more of a radical surgeon, so I prefer doing it radical dissections. So what is a complex fistula? Any fistula which can be treated by fistulotomy is a complex fistula. That is more than 2 centimeter, high transsphincteric, interior fistula in females, recurrent fistula, horseshoe fistula, etc. So why we started this fistulectomy with the sphincter repairs? Because sphincter sieving procedures have a success rate of near about 50 to 75% only. And the incontinence is 0 to 4%, and the sphincter cutting procedures have more success rate, but the incontinence is again higher. So we have to combine both of these procedures. So in sphincter cutting with primary repair, we get a success rate of more than 90%, and the incontinence is very less, near about less than 12%, that is minor. So also at times we are having, when you will be doing the fistula surgeries, there are at times you can't find any internal opening, because at times there is fibrosis, at times there is sinus tract, and at times there is hourglass deformity, as you can see it over here. So at times, because of the fibrosis, the dye will not come inside. So at those times you will not be able to remove the offending gland, so it is better to go from the outside in approach and remove the whole tract completely. So this is technical crux of fistula surgery as proposed by Park. So you have to remove the primary source of infection, that is the anal gland, which lies over here. So how much sphincter can be cut? The thumb rule is should not be more than 50% of the ES involved laterally and medially, should not be more than 30% of the sphincter involved interiorly, and in females even do not cut more than 30% of the ES posteriorly. So and always go for PSR if you are doing more than that. So I'm not talking about these fistulas. These are the small fistulas, low fistulas. You can just do a fistulotomy in that. And these are the fistulas which are the higher complex category fistulas, in which you have to repair the sphincter to preserve the continence. So whenever you are doing any such fistula surgery, you should always feel for the anorectal ring. This is the how you should be feeling for the anorectal ring. It should never be divided at any cost. So again, discussing about a case, this is the case of pineal sinus. It was operated outside. So that is a important message, that whenever you are doing any pineal sinus patient or you are planning to operate him, do a PR examination. At times the pineal sinus are joined along with this fistula. So if you only treat the pineal sinus, it will lead to recurrence, and you have to treat both the things at the same time. So this is a pineal sinus patient operated outside, and he was having a non-healing wound since 3 months back. So when we did a PR, we found an induration at 6 o'clock, and MRI came out to be suggestive of 7 centimeter long tract with intersphincteric branch. So this is how we do it. We just put a dye inside, and when you put a dye inside, you can just see it coming outside. So you'll just be seeing it coming inside here. This is the dye has come inside. So it is a fistula, and in such fistula with branches, it is better to do a complete tract removal. So we take an elliptical incision near about to the external opening. We have to take the less incision you take, the more it will be better. and the more you can approximate it later on. So this is the elliptical incision we have taken, and then we will be just following the tract fully. You need to palpate the tract at times so that you can feel for the induration, you can get a good idea where you have to go. Also you can probe this tract from this place. If you are having thin probes, that probe can go inside and you can just get to know where you have to take the incision. So this is, we keep on going through the tract where it is going, and then we take the incision. So you can just see this, we have taken the incision till here, and then it is a high transsphincteric tract. We have taken out the this opening from inside, and this is the eye again supralevator portion going inside. So we prefer taking the whole tract and the whole disease outside, because since it is already recurrent fistula, we don't want any recurrence again. And you can just see this is the branch which is going in the supralevator portion. So you have to be just near to the tract as much as possible. If you are near to the tract, it is a fibrous tract. So if you are near to the tract, there will be very less bleeding. In case you deviate from this tissue, in case you miss the tissue, there will be very heavy bleeding, and it will be difficult to operate in such a bad field. So if you are near, you can just see the extravasations of the dye. This methylene blue along with hydrogen peroxide helps you to delineate the tract. Whenever you are taking the tract out, it will help you. Wherever it is coming out, you have to take a bigger this incision near about to it. So you can see this is the internal sphincter, and this is the tract is going inside. So at times for exposure you need to divide the thing so that you can take it out. But the thing is, it should be cautious with all the people who are starting to do such fistulas. You should not do it in the beginning. After you have done many fistulas, then you should try attempting such difficult fistulas. So just be near to the tract as much as possible. And the thing is, after removing all the tract, what we can do is we can repair everything. So whenever we are doing any fistula surgery, when we are unsure of it, when how much muscle we are about to divide or how much we have divided, we should palpate this anorectal ring inside. So we are just taking it out, and it is almost completely out now. So if you are near to it, there is very less bleeding. As you can see it over here, it will not bleed, and you can do it in a good field. You can just see we are just taking it out. This was the internal opening here. We are just taking the internal opening along with the tract out. This is the portion of this dentate line. This is the dentate line here, and this is the internal sphincter. You can see it over here. Now we are going into this intersphincter space. This is the external sphincter here. You can just see it is just clearly coming out. And so this is how it comes out. This is the branch again. You can just see a small branch going here. So the dye helps you to get to know how much tract you have to remove. Here we have seen that there is no dye coming out from this side. So we just need to take it out. So methylene blue is of a good help, and in every surgery of any fistula surgery, you should put methylene blue along with hydrogen peroxide. It should be, I think I'll rush it up. So you can just see, you can probe it, and the probing helps you to get to know how much it is going inside. So the probe helps you to take it out exactly. I think I should rush it up. Okay. So this is how we are closing it up. We have taken the tract out completely, and these are the simple sutures we can take. In case if the muscle bulk is more, I have told you, we can use PDS 10 or PDS 0 number sutures. And if the muscle bulk is less, so we can use simple 20 sutures. And the crux is that they should be tension free. There should be no tension on it. Like you all are surgeons, you must be doing this abdominal wound closures. It is a simple closure like that. You just have to approximate the muscles. And the thing is, they should be very less tension free, because the patient has to sit on the bottom and everywhere. So in case the tension is more, all the sutures will come away, and then you will have to remove it. And there also the crux lies, you should never remove you should preserve the anorectal ring at any cost, because in case that is divided, that will lead to a havoc in your surgery, because even the recurrence is acceptable, but incontinence is never acceptable by any patient. So you can just see, this is how we are taking the simple sutures. I'll show you the final image how it looks like. These are just simple sutures, not much into it. And the thing is, see, you see the depth of the wound is very much. So after just approximating the sphincters, what we'll do is I'll marsupialize this layer to the skin so that the wound size decreases. So it also helps. This is how it appears to be. We have repaired the sphincter. We have marsupialized all the edges. So it has become a smaller wound. And what we can just irrigate it properly. This is how the patient has to dress also when he goes home. He just have to wash with normal saline. The normal saline washes are good enough for any dressing. And you can see this is the tract. It came out near about 7 centimeter with a branch. So some follow-up of our patients, like this was a fistula, we just took it out completely, repaired the sphincters and marsupialized it, and this is how it heals up. It is a very good cosmetic scar which comes out, and this is near about a 11-12 centimeter tract. So again, this was a fistula patient which are having 3 or 4 openings. What we did was we did coring of all the coring of all these tracts, and I also did an internal fistulectomy. But the internal, you can just see the dye coming from all these are interconnected. Near about 7 or 8 openings are there. So we cored it up. We did an internal fistulectomy. I thought that will be a minimal invasive procedure, and it will not only treat the disease, but also there will be no problem in this. But it recurred, and I could pass a probe inside. This was not healing up. So finally I did a fistulotomy of this wound, and it healed up completely like this. So again, you can just see a patient. I tried closing the skin also, but the skin sutures gave away like this. So I stopped closing the skin after it. I only do so these are some more follow-ups of the patient. I'll just rushing up. You can just see a gluteal fistula. We have done near about 11 centimeter tract has come out, and this is how it appears to be cosmetically good. And some more fistulas. And this is a paper from Rato that 93.2% success rate is there by him in a study, and only very less 12.4%, mainly some soiling is there, but that too also is controlled by Kegel's exercise. So it is useful for high transsphincteric fistula. The anorectal ring is never divided. Success rate is more than 90%, and no significant incontinence is there. So a successful fistula surgeon one can maintain a fine balance between the incontinence and recurrence. Thank you.
Thank you, sir. I would like to call Dr. Hari sir to present the memento to the Anshul Shah sir. Next presentation is set on when and how by Dr. Shanti Vardhani ma'am.